Welcome to Sirens Stethoscopes. Today we're talking about acidosis, hypothermia, and coagulopathy come together to make our Triad of Death. So let's get into it. All right, welcome back. I'm your host, Kevin. I'm joined today by Jay. Thanks for joining us, Jay.
Hey, how are you?
And we're going to talk about some of the sciencey things on how bleeding actually kills somebody so that we can stop it.
Right.
That's our goal. Let's stop that. But before we dive into that, it's been a while since you've been here, Jay. Thanks for coming back.
Thanks for inviting me back.
Yeah.
Glad I didn't ruin my last opportunity.
I missed you, so we had to have you back around. But I actually learned this science from you a handful of years ago that you presented this material. I was like, that's pretty interesting. I like learning some of this stuff. So you were forefront of my mind for this conversation to have, because
Nice.
in my mind, you're my resident expert on this stuff. So we're really glad to have you here.
Well, thanks. Well, thanks for having me.
Why don't you remind us who you are, where you come from, and what kind of background you got?
All right. My name's Jay Barrera. I am the Battalion Chief of EMS Training for Harris County SD 48. I took over when you left, and so learned a lot underneath you on how to do a lot of things, and so stepped in, tried to kind of make it my own, but just kind of build onto some of the things that you developed. Got my degree in EMS administration at the age of 49, so it's never too late. And then been with ESD 48 for I started in 2009, so however many years that is. Got into EMS late in life. It was 2005. I was 35, and honestly, I just needed first aid training for a camp that I run. So.
And fell in love.
And fell in love or fell into a hole. I hadn't figured out which one yet.
One of the two. Let us know when you find out.
Right. But beyond that, that's me. I enjoy what I do. I like helping people. I like trying to figure things out. I like trying to, figure out the puzzle of whatever's happening and then go from there.
Awesome. Today we're going to talk about this, and sometimes we come across this occasion in our classic trauma management, and we're going to talk about bleeding in general. All bleeding this pertains to, but trauma in general, we get this trauma case, and somebody's really injured badly, and we do some things to make them a little better,
right?
And we deliver them to the trauma center, and we hit the golden hour. All these things are great, and we're kind of high-fiving. We're feeling good about this, and the patient never leaves the hospital. That they die a couple of days later, and we're like, what the hell? That doesn't make sense. What gives? Like and we're going to answer that question today.
We're going to try to.
What gives?
Right.
That a lot of the things we're going to talk about to help us understand that just because things are a little bit better at delivery to the hospital doesn't mean that we stopped all the things going on. And there's a lot of factors at play, especially when we're talking about massive bleeding and hemorrhaging and getting into this triad of death. So I want to save coagulopathy for the last of the three, but I'll let you pick. You want to talk about hypothermia or acidosis first?
Well, I think we probably should just start with hypothermia because that's what we're going to see first.
Okay.
It's something we can actually see occurring as they get cold. They're going to start that shivering process. And I was actually, when we had talked about doing this, I thought back, there's a scene in one of the Lethal Weapons. And Joe Pesci's character gets shot. He's on the ice rink, and he's lying on the ground. He's like, "Oh, I'm so cold. I'm so cold." and I remember at that time, I'm like, "Well, why is he?" I mean, obviously he's cold because he's on the ice, but why is he cold? And why do I see that a lot of times in movies that they start talking about that? And there's actually a reason. You're starting to lose blood. You're starting to lose that ability to circulate and regulate body temperature, things like that. And so all of a sudden, you start to get cold. And most of the time, at least in the past, not so much now, I think we've learned a lot in medicine as we've gone along, but a lot of times we would grab, when EMS gets there, we'd start our line, we'd grab our bag of saline that's been sitting at room temperature in the ambulance, which is usually about 72 degrees, and we would start giving that, and we weren't helping them by warming them. We were making them colder.
Making them naked.
Right? We're making them naked. Yeah, we're stripping them down. Well, hopefully we're stripping them down, figuring out what's going on, doing our trauma assessment. We're starting a line. We're giving them cold fluids, whether they were meant to be cold or not, and we're contributing not only with their temperature, but we're also throwing a very acidic compared to the body, right? Because I think saline's 5.5 or 5.6 on a pH, and so we're dumping that into them. So we're already trying to work behind ourselves because we're not doing anything to help them, right?
Yeah. And I worked a couple of years ago, 1 or 2, before I went to school. I worked in a trauma center, just the one that was nearby as a tech, and we had this. It was called Bear Warmer.
Okay.
You know, like it was this inflatable blanket thing that you'd wrap somebody up in, and you connect it to this blower, and it just continually blows hot air to circulate around you. I'm like, well, that sounds pretty cool. Whatever. What good does this do at a trauma center? You know, here we are.
Yeah.
I just figured because we're Chicago, it's cold here, it snows. We should warm people up. But even before we get into what saline does, we're talking about being cold and some numbers that the body stops clotting at about 95 degrees-ish, right? Like we get below 95. And let's talk about how easy it is to hit a 95-degree core body temperature when you're hemorrhaging.
It's a pretty simple process. And talking about going back. So if we go back to, we're dispatched to whatever the injury is, whether it's a gunshot, whether it's a car accident, whether it's somebody fell, whether it's a GI, like whatever it is, some reason blood is not staying where it's supposed to be, right? Whether it's going on the sidewalk, whether it's going into the belly, whatever it's doing, it's not where it's supposed to be. And of course, that helps, perfuse our brain, our heart, all these things. Well, if we're not getting, oxygenated blood to our brain, that's going to affect our temperature because that's all controlled up there, right? But then we get on scene, walk up to our patient. Hopefully we're doing a true rapid trauma assessment, and we only expose what we need to expose for that moment. But a lot of times, depending on where you work, what your service is, what your experience level is, you get there and you're like, oh, I got to cut the clothes off, right? So we strip them down right there wherever they're at. We expose them to the environment and the elements. No matter what, whether you're in Chicago where it's cold or you're in Houston where it's humid, they're losing that blood, it's going out, and we have now just opened it up to that light breeze or that whatever's happening in the environment. If it's raining, and now we've just given them another opportunity to get colder.
Yeah.
And then of course the body's going to kick in, right? Try to do what it does to stay warm, and so it starts shivering.
Yeah. We're going to hold on to that piece. That's going to send us right into the acidosis end a little bit with the saline.
But typically that starts happening at around 95 degrees.
Okay,
right?
yeah.
So you're going down, boom, this starts happening, and we've got to address it. And it's something very easy we can address.
Yes.
You don't need to be a paramedic to know, because ultimately you're in a shock state, right? So from Boy Scouts, what do? Well, you lift the feet 6 inches, whatever, I don't remember the length of it, and you cover them with a blanket. Try to keep them warm, try to keep that core warm. That's what we can do, right? In the immediate.
Everybody can work that thermostat.
Exactly. That's the next thing. We get them in the back of that truck.
We got to crank, right? We talked about it in a previous episode, but you should be sweating buckets, right?
Absolutely. And not the patient. You as the provider.
Yeah.
If you're not sweating, it's not warm enough.
Yeah. Because realistically, 95 is easy to hit. 90 is our next crucial point.
That's right.
That we start flirting with 90, and that mortality rate is going to skyrocket. That we might keep this person alive for the next couple of hours, but here we are. We'll work down the pathway. These are the people that we got them down to an 89-degree temperature, even 90-degree temperature. We just really eliminated any chances of survival.
Yep.
No matter what amazing surgery is going to happen, no matter what kind of mass transfusion protocols, we've already done damage.
Absolutely.
And you're right. Rapid intervention, warming them up, very important stuff to do up front.
Absolutely.
All right, so we fill them up with saline, which is acidotic, like you said.
Well, hopefully there's a lot of different fluids out there.
Classically, we'll take saline.
Right.
So if we go with saline, acidotic solution, room temperature, probably likely that any fluid, any crystalloid solution we pick is room temperature.
Right.
Back to the hypothermia. But you talk about the shivering. We're going to make this shivering. We lose blood. We lose the red blood cells. We lose the oxygen carrying capacity, but muscles are still functioning.
Yep.
But not in an aerobic respiration state. We now shift to anaerobic respiration. We produce a lot of dirty waste product, lactate specifically, which puts us into
acidosis.
Man, now we're talking about acidosis. So we have all these challenges. And shivering, the body's trying to help itself,
Right.
just makes it worse.
Absolutely. So the body doesn't, the body knows what it's trying to fix. It's looking at one thing, right? Oh, I'm cold. I've got to get warmer. And it starts shivering, and it develops lactic acid, right? And here we go. So our normal pH on a human, between 7.35 and 7.45, right? We start developing that lactic acid. It's going to start lowering that pH, make us more acidotic. Now, as the genius paramedic that I am, coming in to save the world with a bag of saline, right? Like you said, 2 large bore IVs, great. Hopefully we can get them. If not, we're drilling them, right? So we've got access. Open them up wide. Hey, the pressure's going down. I got to maintain this pressure, and I got to do all this, and all I've got saline, we're at 5.5 on my pH. Well, now I'm just making it worse.
Yep. And let's not forget that the actual damage itself busts open cells, the intercellular contents spill all over, and that contributes to more of the acidosis. And the real kicker is that the best system we have to buffer out acid is breathing, is our respiratory system.
Right.
Which I may still be breathing just fine. There's nothing carrying waste product to the lungs to eliminate. It's just accumulating.
Yep.
Right. So that ties into the proper fluid choice for resuscitation is perfusions, but we're trying to restore not necessarily blood pressure, the perfusion.
But you think about it, when we learn early on, right? EMT school. Hey, my pressure's low. I got to get it up. And you don't think about, it doesn't carry blood, doesn't carry oxygen. It's volume. That's it. Yeah. It's taking the place, but other than the volume, it has no benefit, right? And this is true. If you haven't addressed where the bleeding has occurred, if we can see it, now all we're going to do is make, the pink Kool-Aid or whatever.
Yeah, whatever Fisher says.
Yeah.
Right. Okay, so, but back when you started, you said 35, so like 2 or 3 years ago.
Right.
When you started.
You're so kind.
What?
I'm actually inverse now. It's 53 now. So
What options were there, right? Like
that was it.
We can talk about lactative ringers, get into that, and Roy and Johnny kind of stuff, but that fell out of pre-hospital favor way back.
Right.
This is a matter of we learn better and then we do better. And it seems very futuristic to talk about we're going to do blood transfusions in the field.
Right.
But then on the other side of the coin, it seems so common sense that this person has lost an awful lot of blood. Why would you give them anything besides blood? It doesn't. Right. Seems like it makes a whole lot of sense, except we inject salt water instead. All right. So acidosis comes out of our poor circulation, or our poor perfusion from our poor circulation, because it's all on the ground and not circulating.
Right.
Which makes us cold. Because we're wet in evaporating, losing heat.
Absolutely.
In addition to losing the cellular metabolism that actually produces the body heat, we don't have any more. So these two are just kind of feeding back and forth on each other, which send us down a really dark road towards coagulopathy.
Yes.
And before we even dig deep into coagulopathy and what it is in a specific condition, there's a difference between deranged clotting towards coagulopathy and just over-bleeding the clotting capabilities. So there is a difference, and I guess our goal is to take bleeding more than we can clot and catch that before it becomes coagulopathy and deranged clotting, which, before we jump too far, blood clotting factors like a normal body temperature and they like a normal body pH.
That's exactly right.
So as we deal with hypothermia and the acidosis, we are further debilitating our clotting abilities, which then makes us coagulopathy. What tell us about coagulopathy? Like, what really are we looking at?
So, ideally, you're looking at the liver, right? That's where most of your clotting factors come. You've got some from the kidneys as well, right?
Okay.
So, and I don't know the specific numbers, but I know the pivotal factor 10 is coming out of that liver. And so, if I'm bleeding out and I'm not getting that blood and I start to get cold, my metabolism is going to slow down. My liver's not going to be able to work as well. And this is saying that I wasn't injured in the liver, and now I'm maybe bleeding.
Had a healthy liver to
I had a healthy liver. Yeah. And so people that are chronic alcoholics or people that are possible drug users or people that, may have some type of liver cancer or something that makes your liver not well already, you're already fighting against yourself, right? So We got to take care of that liver. We got to take care of the kidneys, and there'll be another thing that we'll talk about here in a little bit about that. But ultimately, what we need is we need to make sure that we can keep that patient warm, to keep that liver functioning, not have that metabolism drop and slow down. We need to make sure that they're not becoming acidotic with a high lactate, because that's going to affect your clotting ability, right? So now, coagulopathy, pathy meaning it's always bad, right? Coag is, the ability to come together. We're not able to do that. It's not working. It's not necessarily that it can't work. It's something is broken. Obviously, in this case, blood is not where it's supposed to be. And we have to address those things to ensure the body has the ability to try to help heal itself. We're going to have to help it. Physician's going to have to help it. A surgeon's going to have to help it. So we've got a path to go down here, but we have to do our part in the field as paramedics, as EMT providers, as firefighter EMTs. We all have a say, and we all have a way that we can address all of these things so that we don't get to that coagulopathy part.
Yes.
Because that can be avoided. I mean,
precisely. And that's where our mortality rate starts to climb as these come together.
Right.
And we'll talk about the proper fluid resuscitation of it, that resuscitation piece is what brings us back from those higher mortality rates and the timeliness of it. But we can have somebody who's cold. We can have a high lactate production, but we may not necessarily have coagulopathy yet. If we can control the bleeding, we can keep this person warm and back up and start to ventilate them and eliminate some of this waste, which to eliminate the waste, we need some oxygen carrying capacity. We can get to that in a minute. But you're right. Like this, we can disrupt this process because there is a point of no return. It can appear like there's return, but they have crossed the point of no return. And we talk about coagulopathy and in a general sense, but this turns into full-blown DIC, to that disseminated intravascular coagulopathy. And that's where areas that aren't bleeding start clotting or start clumping up, that start having, I guess, best way to equate it is little strokes around the body. That little areas get clotted off, and then they start to die, and then this area dies. And organs do very poorly when they're not perfused.
Correct.
So you're right. This lower metabolic state isn't perfusing the organs that we need to work, but then the intestines start to die. Everything,
Right.
So, all right, coagulopathy, man, holy cow.
And the other thing too, and as you were talking, I was thinking about it. You talked about like these little strokes, right? Well, if you take just the little stroke example of that, right? What do we have? How do we get rid of that normally? Well, we're either throwing some type of thrombolytic at it, or we have to go in and pull the clot out, depending on where it's at and what we're able to do. Well, we already have a problem with somebody bleeding. Now they're clotting where they shouldn't be clotting. And, the quick thought is, well, I got to bust up that clot. Well, if I bust up that clot over there, I'm going to bust up whatever clot I've got that's hopefully starting to form wherever my injury is.
Yeah.
And now, I'm working against myself, and it's just not going to go well. And like you were saying, we've got to jump in early, disrupt that process, and be able to help that patient where they're at.
Absolutely. And this is where our golden hour comes from, is correcting this was the goal of the trauma team at the hospital. But if we can get into the hospital within the 60 minutes, we can catch them and pull them back, because we'll control the bleeding, we'll maintain body temperature, we'll correct the body chemistry, we'll get them properly fluid resuscitated with blood and blood components and their MTP, with mass transfusion protocol, which is all great, all true stuff, except from the time of insult to the time of that, 60 minutes becomes a lot of time.
Right.
And
think about how fast time flies when you're in the middle of that situation.
This is true, right? Especially if we get somebody who's entrapped in something.
Right.
Some type of machinery incident that takes 45, 50 minutes to get them out of there. That clock already started. And a lot of the research I was looking at, a lot of the articles talked about the time from activating the mass transfusion protocol, which I interpret as they identified the need for it. So picked up the phone and said, hey, MTP, start sending up the cooler of blood.
Right.
And the time the cooler was there and available at the patient's bedside to deliver blood, that this activation to cooler time was the strongest correlation to mortality rates. Because pretty quickly we're then giving it, and we talked about it in a previous conversation, that activation time happens at the hospital on paper. we're really the activation time.
Absolutely.
When we identify this patient as a massive trauma, this is a level 1 candidate, they need surgery, we put a helicopter in the air or make the decision to go downtown, that's the true activation time.
Right.
And that time to the cooler at the bedside at the trauma center, that's a big gap of time.
Absolutely.
So this is a phenomenal opportunity to take that cooler from the trauma bay and put it at the trauma. And what we actually start to see is less need for mass transfusion protocol activation, that we see a unit of blood in the field or two, we see another unit, maybe another one throughout the night. But it's kind of like the Levophed argument, right? Like people get on mass transfusion protocol and it comes with an associated mortality rate. That people just don't do well when they're on mass transfusion because of how sick they are. They're already in this mess, right? So it's not Levophed kills people. No, we give Levophed to people who are really dang sick.
Correct.
We give mass transfusion to people who are really dang sick. So not only are we correcting some of this triad stuff, we're keeping them from having to go into the extremes of treatment because we've prevented the extremes of damage,
right? Or hopefully we've at least slowed it down exponentially.
Correct. Yeah.
I mean, they're probably still going to need surgery. They're probably still going to need, like you said, some blood, but maybe not that mass transfusion protocol, which now, and the thing about that, and the reason, and I don't know, the audience, what they know, but a lot of thing in the field now is whole blood, right? You get to the mass transfusion protocol, it may be packed red blood cells, 3 of those with a plasma, and that's all great, but each one of those has its own citrate. So you're going to get more citrate, which actually is what blocks some of that ability to carry oxygen and prevents some of that clotting to happen. Versus, hey, I've given 2 units of whole blood, I'm going to have a much lower threshold of that citrate in that, and so it does more to help that patient than by the time they get there.
I like it. That's a new piece of information. So we're going to come back to citrate,
okay?
Because that is absolutely a concern we need to have, because we give somebody blood, and that's not the end of the story,
right?
We were talking about. All right. So anything more about hypothermia and acidosis and coagulopathy that we really haven't? And again, right? These all feed on each other,
right?
When we can't clot, we continue to bleed, we continue to lose body heat, we continue to shiver to produce more lactic acid, blah, blah, on and on, right? And here we are.
But to go on it, to recognize the trauma or the diamond, whatever you want to call it, right? But all of that is going to be dependent upon the assessment your provider does at the time they get to the patient or as they're walking up. I mean, you can look at somebody, if you've been in EMS long enough, right? Or the fire service long enough, you walk up to that patient and now all of a sudden, oh my God, they look white or that gray, like just that look of death almost, right? That's where your assessment begins. That's where you're going, oh, it's time to go to work, right? It's time to earn the big bucks that we make. Okay.
Right. And since the time that you taught me about pre-hospital blood transfusions, by the way, Jay taught me, there we go. Since I learned this from you, I learned that it's not as hard to pick these people out as it seems. Like, hey, we're going to do a blood program, and it's the holy cow, who needs that?
Right.
You know, guys, you know.
Be surprised too.
You know, okay? It's and I tell people that it's not, here's the vital signs you have to see. You're going to look at somebody, and oh man, that person just puked some blood, and they look like this.
Yeah.
You touch them, and you're like, oh boy.
Or there's a huge pool right next to them, and you're like, that's not normal.
Right? I mean, there's some pretty dang apparent ones. You're like, yeah, that makes sense. It's going to be easier to pick these people out. Would you agree with that?
Absolutely.
Right. And then it is. It's just that gestalt builds and experience comes in, and that's going to be one. That's going to be one. Gut said. It's not as tough. But you're right. That assessment, actually taking in information from your patient, is pretty dang crucial.
And one more thing I wanted to add too, when you were talking before we move on, the hypothermia, the tool that we're going to use to determine that, thermometer. It's not rocket science how to use that. Now, best way, nobody wants to do it, rectal, get that core body temp. But when we move to acidosis, well, now, how do you determine acidosis? We don't have a way to do a blood test, or we don't have a way, we're not carrying I-stats, right? And you mentioned it earlier with our respiratory, and it's our end tidal.
My favorite.
Our end tidal is going to be what's going to help us there. Yep. So we've got to get it on, whether it's a nasal cannula, whether it's putting it between the BVM and the mask. It's something that tells us, hey, am I getting good gas exchange down there at the cellular level?
Yep.
And if I've got, high end titles, I'm blowing off a lot of carbon dioxide, I'm probably acidotic, right?
And realistically, in these cases, I'm just going to go on a limb and say it, I'd rather have a person with a higher end title than an end title of 12.
Oh, absolutely.
14,
absolutely.
Right? We can have a whole nother discussion about that one, but to get an end title reading, you have to have some pretty good cellular things happening. Yes. Not great. It's not great. Right. Work to do. But when your end title's in the teens, there's some things missing that we really want to have happened. So, yes, I'm with you.
And now you move to coagulopathy. Well, how do I know if they're in that phase? Well, where's the blood? Where's it going? Is it still on the floor? Is it something we can stop with a tourniquet? Is it something we can stop with wound packing? Is it something we can stop with direct pressure? Or is it still going on?
Yeah.
And then to throw another caveat with you on that one, now you've got this trauma patient and they're an AFib with RVR patient who is on therapy doses of Eliquis, warfarin, whatever. They're not going to clot. Right? So now I've got to worry about that. And so there's a whole lot of things that can progress and make our work even harder. And then, what do I do about that? I mean, I got somebody who's bleeding profusely, and nothing I'm going to do is going to stop that clotting. Does TXA work? I don't know. If I'm within 3 hours, great. If it's a GI bleed, I'm not giving it because I don't know when that bleed started.
Right.
If it's trauma, well, maybe. But again, what's going to go on? I know warfarin's got an antidote that's vitamin K. I don't carry that on my truck. Do you carry it on your truck?
No, I actually have a friend whose child is hemophilic, has hemophilia, and that's the vitamin K, a nice factor in there. Outrageously expensive.
Oh.
It is like he tells me these dollar amounts, and I hurt for him.
Right.
But what else are you gonna do?
Yeah.
Anyway, I digress. No, I don't carry it.
Right.
I don't carry it.
Right. And now I know it's expensive.
Very.
So we're probably not going to be carrying it. And how many people are using warfarin now? They've got Eliquis. They've got, what's the other one? There's like all kinds of them out there. And so that's another factor that you throw into that.
Yeah.
And, we've got a lot of work to do. And
yes.
And again, we've got to recognize, yes, we need to know what's going on underneath. But all this, again, goes back to assessment. And I push on assessment because to me, since COVID, it seems like a lot of people are verbalizing or thinking, okay, I've looked at the chest, I've looked at this, but nobody's putting hands on. Nobody's looking to see, hey, where's that blood coming from? And so, and I don't know if it's a COVID thing. I don't know if it's just something people got relaxed in doing, but the assessment is so important to all of this that, yeah, I can see that we've got a trauma situation or a bleed situation. Now I need to recognize what's happening with the body so that I can try to help them. Versus, I'll just put a Band-Aid on or, tourniquet and we're good. No, there's a lot more behind that. And everything is dependent on your assessment. Everything determines where we're going, what we're doing, all of it. But recognizing these factors in that, whether it's a traumatic patient or the GI patient or, whatever, internal bleeding patient, if we don't recognize what's happening, like you said in your first example, yeah, we might get them to the hospital and pat ourselves on the back, but if they don't walk out of the hospital, it's all for nothing.
Yeah, that's the win when they get to walk out. But let's talk about how this is killing people. Our interventions, our stepping in here. We got to control bleeding.
Right.
Number one, that if the bleeding is causing the trouble, then let's stop the bleed.
Right. Exactly.
Stop the bleeding. Body heat.
Yes. Blankets.
Temperature. Or create it. Either one, both.
Or both. Yeah.
This patient's got to be ventilated.
Yes.
So we got to be oxygenated and ventilated. Right. This is not intubated.
Correct. It might be they need intubation.
It very well may be.
But it doesn't mean that's what we do.
Let's talk about the fact that we might give this person whole blood, get them perfused, and their mental status goes up.
Oh, yeah.
Dramatically.
I've seen it happen.
Yes. We don't need to intubate. This person, Dr. Humphrey used to call it an airway death. These people aren't dying in airway death.
Right.
Maybe they are, and they need that airway management. If somebody's bleeding from a massive abdominal injury, that's not an airway death. Right. Like they need to be oxygenated and ventilated, yes.
But that's where we also talk about resuscitation before intubation.
Yes.
You got to address your hop killers. Why are you having a hop killer? Hypotension. What is it? Because you're dealing with a bleed.
Yep. And then we need to volume resuscitate this person.
Correct.
With the appropriate fluids.
Yes.
And let's take a quick second. We'll come back to volume resuscitation in a second.
Okay.
But let's talk about the auxiliary medications and the supporting medications. that we're making it a practice to still give TXA with blood, because the blood will have these clotting factors in it. TXA doesn't clot blood. It helps blood clot. But we have to have something to clot.
Right.
So we go give the things to clot and the helper to clot. Man, I got my fingers crossed that these two are going to play nicely together and really help control the bleeding and not make it worse. Pain management is kind of a later thought.
But pain never killed anybody.
This is exactly what I was going to say. Man, this is why we're friends. Pain doesn't kill people.
Right.
It sounds inhumane. Pain doesn't kill people. Hemorrhage kills people.
Right.
Infection kills people. That maybe the antibiotics in these kind of traumatic cases are a consideration once we have some stabilized hemodynamics.
And I will say pain medicine may also take out your sympathetic drive that's keeping you going.
This is true.
Because now you're relaxed. Now you're not going to be breathing. And now we have caused you to be worse because we treated your pain. I'm not saying we can't treat the pain later. But let's stabilize, resuscitate, stabilize, do all the things we need to do before we consider pain management.
Very, very valuable point to make.
Yeah.
And then there's one more medication, because citrate is the preservative in all these blood products. What trouble does citrate even cause us? Why are we talking about it? And how do we handle it?
So citrate is, like you said, it's a preservative that helps prevent the whole blood or whatever you've got from clotting on its own, right? It's kind of a stopgap so that, hey, I can give blood to my patient. I can give, whether it's packed red blood cells, whether it's whole blood. It keeps me from having to go, oh, it's just a giant clot now, so it's no good, right? And so one of the things that occurs when you have heavy hemorrhage is you become hypocalcemic. So your calcium level drops. And calcium is extremely important for a lot of different reasons in the body, but it also helps with clotting. It helps with those clotting factors in the liver, right? And so there's a lot of research out there that talk about giving calcium after your first, if you're giving blood, after your first administration of a blood product. Now, and this is when, right before this we were talking about, this is where you have a conversation with your medical director, have a conversation with whoever's in charge of coming up with your guidelines and all that, because you'll find some doctors that say, hey, give it after the first one, and you'll have some doctors say, you know what, you don't really need to give it until mass transfusion protocol is in place. And it took me a while to kind of figure out, well, why is that? And that's, I think we talked about that too, but because that you start giving all those different components and all those things, you have a higher volume of citrate in multiple bags of blood products than you might in one bag of whole blood, if that's what you carry, right?
Yes.
And so I can give that. Am I worried about the hypocalcemia at that point? Probably not. Are they hypocalcemic? They might be. Chances are they are, but it wouldn't be that severe hypocalcemia, right? It's not. It's not to that point where, oh my God, we've got to work against ourselves.
And not just the like the citrate makes a bad thing worse.
Yes.
That the citrate and the calcium bind up, and they're going to metabolize together.
Yes.
And not in your classic way.
You're talking about before we decide to give calcium.
Correct.
Okay, yes.
Calcium in the body, the endogenous calcium.
Yes.
It's going to get consumed binding with citrate, which is preserved, right? We're already low on it. It binds with the citrate, not functional to use in classic calcium ways.
Correct.
And you're right, that a unit, not so concerned. There's a lot of literature that says 1 unit of blood is not a concern on the hypocalcemia and the citrate and everything else. I think about when we deployed antibiotics for trauma in the field. That somebody's not going to die in the next 30 minutes from an infection.
Right.
But we take this opportunity to move interventions earlier.
Get ahead of the game.
Get ahead of the game, because, excuse me, so many other things are going to happen. And what are the chances of that intervention falling off the list because it's not an immediate life-saving intervention? So we move it to the field. We give antibiotics in the field for trauma, and it improves outcomes and cuts days off of stay level. And you'll get, like you said, talk with your medical director, but you'll get those physicians that push for it early. And that's my understanding, is that's why, is we give a unit of we give a gram of calcium early. By the time they hit mass transfusion and somebody gets blood work 8-12 hours later and then identifies, oh, hey, wait a minute, the calcium is a problem, let's treat calcium, we kind of get ahead of it. Right. Varying opinions, different takes on things. Generally speaking, citrate exists.
We have to address it.
We have to address it. It makes us a concern with calcium, and that's our concern.
Yes.
And that is where it's a really good discussion point when you want to go have that discussion of where does calcium fit in with me as the provider and really this patient's entire clinical course. That's really the discussion, is where does it fit into the clinical course entirely, because we have just a little sliver at the front. But you think about an airplane, right? Like if you're off course by 10 degrees, you end up in a whole different place.
Oh, absolutely.
At the end of this line. And that's what we are, that we get to kind of set the course. And what a powerful thing.
Yeah.
What an amazing opportunity to set the course right. I mean, that's some good pressure, but pressure is a privilege. I mean, you can perform. So that's where citrate becomes in. Calcium becomes a good discussion. And anyway, now I'm just going on and on about calcium and citrate.
That's right. But it's good. But then you have to also determine, do I use calcium gluconate or do I use calcium chloride? And I forget what exactly it is, but calcium chloride is 3 times, I'm going to use the word potent, but I don't mean it that way, but 3 times stronger,
concentrated,
more concentrated, something to that effect, than calcium gluconate. So you would have to use more calcium gluconate versus 1 gram of calcium chloride. Now, the other thing that they tell you is, you can only push calcium chloride through a central line. Well, we're EMS. We're not doing central line.
I don't know that I've ever pushed it through a central line.
Right.
Mostly because I've never pushed anything through a central line.
Me either.
So
the big thing there is, it can cause tissue necrosis if it extravases, that
it
word.
goes outside. Yeah.
Yes, thank you. But, can that happen? Sure. Have I had that happen before? I don't think so. I've never had anybody come back and say, hey, man, you destroyed my arm because you pushed calcium chloride. But we do have to be cautious. We have to be careful about anything we push and recognize the risks. But you're better off, if, in my opinion, my personal opinion, you're better off using calcium chloride than you would be calcium gluconate. I can't tell you the differences in price. I think they're pretty close. But if I have to use 3 times more of one than the other, give me the one I only have to use one for. That's going to last that patient a long time.
For us, we're already carrying it. We already use it in other, indications of things.
Right.
So it's kind of now becomes economy of scale kind of stuff.
Yeah, exactly.
All right, let's go back to the volume resuscitation piece.
Okay.
Because this is where we're going to bring this thing home, that it's great. Let's just give all kinds of blood.
Right.
If a little blood's good, a lot of blood is great. Just load them all up and fill them all up.
Yeah.
No, right? There is a concept called permissive hypotension. Help us understand permissive hypotension.
So we have to decide where we want our threshold, right? Where things are going to happen. So let's just say we're addressing everything, okay? We've addressed the hypothermia. They're warm. We've got their body temperature up. We've addressed the acidosis. We're bagging them. We're oxygenating, whether we've intubated or not, but that's being addressed. We've kicked the temperature up in the back of the thing. I'm sweating like crazy. I've got 2 large IVs going, and I've infused some whole blood, right? And so now, kind of like you said, a little must be good, so a lot must be better. Well, what's that limit, right? What's my threshold that I want to keep?
There is too much of a good thing.
That's absolutely right. And so we want that permissive, so we're going to allow a certain amount of hypotension, low blood pressure, to stay there so that we can keep our patient perfusing the organs that we need to keep perfused, but not raise it up so much that I'm like, well, I've got to have a blood pressure of 120/80. And one of the things in my department that we use for that is MAP, a mean arterial pressure. I don't know which monitor you use, but if you use a Zoll, you get your blood pressure here, and there's a little number in parentheses right next to it. That's your MAP. Calculating is very easy. If you get a manual pressure, it's 2 times the diastolic, so 2 times the bottom number, plus the systolic, divided by 3. And for us, we've kind of set 60 to 65 as our lowest target that we will allow it to go. Ideally, we don't want it to necessarily go above 90, because again, if I allow that pressure to build up too much, I might actually pop a clot inside, the clot that is formed to help prevent that bleeding, and now I've just put more force behind it, and now I'm now fighting the same battle, right?
Yeah.
And so that's what the permissive hypotension is. is we're allowing a certain pressure there, and it's to perfuse the organs we need. Maybe our kidneys, obviously our brain, all of our major organs that we need to get. I can live without an arm. Do I want to? No, but I can. Can't live without a heart. Can't really live without kidneys. Can't live without a brain.
Yeah.
Even though some people might argue that I've been doing a pretty good job so far.
Right. It is. It's going to be this kind of a hard thing, right? It's the minimum.
Yes.
That for all of the discussions of performance that we have and working hard and doing your best, here's the opportunity to do the minimum. We want the minimum amount of perfusion to keep these organs in line without too much that causes the trouble, like you talked about. There's also some literature that supports the idea that if we fill up this tank so much that we get some really good pressure in the vasculature, the heart recognizes these changes, reduces the force of contraction in the heart, reduces the cardiac output to equalize. We then lose pressure. And we just kind of go in this cycle. Well, then we're going to give them more because I want to pressure up, and the heart's going to try and equalize the pressure. Again, compromising the perfusion. The goal isn't make some blood pressure, it's make the perfusion.
Right.
So this, man, it's a tough thing. Hey, just the minimum. Just do just enough.
Just do the only time you'll ever hear Kevin say that too. Yeah. I just only want the minimum out of you.
Probably. Yeah. And that comes from paying attention to your patient.
Yes.
Identifying these reasons why we're resuscitating them in the first place and what changed out of our initial indications. That's one of my favorite things. Whatever you looked at to decide to do something, look at the same thing again.
Right. Did it work?
See what changed. Right. Yeah. Does it look the same as it did 20 minutes ago? It's not effective therapy.
Right.
For whatever reason. Right. The patient's not responding to it. Blah, blah. Right. We go put 3 units of blood in somebody and don't control any bleeding. You're probably not going to get a change in that indication for giving blood.
And you're going to be cleaning out your ambulance.
Oh, that'll be right. So it's also interesting that classically it would be 2 large bore IVs, lots and lots of fluid, just let them run, pressure infuse. We don't see that with blood transfusions. What's the most you've put into a single patient?
I personally have only given 1 unit of blood every time I've given it, which is maybe a handful of times, maybe 1 unit of whole blood. And that's been, to see their color return, to see and it's about 500 cc's, maybe a little bit more.
I was going to say,
it's not much.
Depending on the packaging,
right?
You're really topped out at 500 milliliters.
Yeah.
For a dying, injured, hemorrhaging patient.
Yes.
500 milliliters of magic juice.
Magic juice. I like that.
It's incredible, right? The reason we used to infuse piles and piles and gallons of saline is because it did nothing.
Correct.
That the vessels would leak. We would just continue to swell areas of the body, and it would cause more vascular damage and not actually be circulating volume, or even a small portion of it would be. So now that we have an on-target treatment, that it repairs the endothelial damage in the cells, it reduces the inflammation, it keeps the volume in the vasculature where it's supposed to be.
Right.
This is why we can allow permissive hypotension, is that even if we have a soft blood pressure, we have a systolic that we typically wouldn't really like to see in a trauma patient, we can be okay with, because the targeted therapy is it's on point. It's right. And you had mentioned some of your targets. What I'll tell you is look for these shock indicators. Again, the things that told you need to resuscitate this patient: end tidal, skin parameters, mental status. I like looking at heart rate. This person has a heart rate of 140, and you give them some fluid, and they look a little better, and their heart rate's now 110.
And quality, right? Is it thready?
It's true.
There's a lot of things like that.
We're getting a good solid 10. End tidal gets better. I mean, these are the things that we're resuscitating to.
Yes.
With permissive hypotension. It is not, here's the number you will hit or else. Again, it's perfusion. And if we've restored some perfusion, we have indicators of perfusion. It's a hard clinical judgment point to have the holding pattern, to say that's enough, let's not do more. Because it is all these things that we mentioned, and we need the next level of targeted therapy in the trauma bay. So,
and we have to make sure too that you are treating your patient, not a number.
True,
right? Like I said, our minimum threshold map in a trauma situation 60 to 65. But if I get them, if I can get them to 70 and it's working great, then that's great. I'm not worried about going lower, right? That's just where my point of no return would be, is I've got to get that up from there. But I can't just count on a monitor blood pressure. And again, I'm not looking at the blood pressure. I'm looking at MAP because you can figure out a map of 60 with several different types of systolic and diastolic pressures. So I have to make sure I'm looking at, is my patient, like you said, breathing? Is my skin color improved? Are they interactive with me now? How's my bagging? Whatever's going on, am I stabilizing my patient? I could get all the great numbers I want, and they could be unstable.
Yeah.
So treat your patient, look at your patient, monitor your patient. The other things are tools. That's,
And one asterisk that we need to throw in with permissive hypotension is that head injuries have their own set of rules. We are going to have higher pressures, higher MAP, and head injuries to perfuse the brain. Whole nother discussion for another day.
Absolutely.
But these rules of permissive hypotension and volume resuscitation we're talking about, when we're worried about head injuries being involved, talk about another layer of complications. That's different set of rules.
Yeah.
This game has ended. You're in the next lane. Whew, okay, here we go. Okay, so a little asterisk on permissive hypotension.
Yes, absolutely.
So Jay, we talked about how hypothermia is bad, how acidosis is bad, how they all lead to coagulopathy, and they make each other all bad, and we just cycle around until we do something, which is controlling bleeding, preserving body heat, ventilating, oxygenating, volume resuscitating with appropriate fluids.
Yep.
Whole blood, hopefully, or components even. Saline, way down the list.
Oh, yeah.
Readily acknowledging that is some agencies' only option.
Right.
That's what it is.
And there are other fluid options out there. I know we moved to Normasol or Plasmolite. They are more expensive fluids. They have a better impact on patients. But you're at the mercy of budgets and volumes and supply chains and all that. And so if you're carrying saline, it just may be what you have to work with. And we've all had to work with that at some point in our careers, right? So, but if you know these other things, hey, I know I need volume. All I've got is normal saline. Maybe I should just give a 250 bolus, or maybe I should just give 100 and then start working the other things so that I can get where I need to get.
And with this, let's talk about you can warm saline.
Absolutely you can.
You should.
Yes.
If that's the only option you have is saline, you're right. Maybe we temper our resuscitation. Permissive hypotension applies in saline volume resuscitations. And so does the principles of hypothermia. Warm it up. Monitor your administration. Don't just go wild and more is better, because that's not true. We're saying too much whole blood is not a good thing.
Right.
Crying out loud. Too much saline is absolutely not a good thing.
Absolutely.
So temper your interventions, monitoring your patient, warm up the fluids, keep your patient warm. There's things you can do without having whole blood in your hand to really make a difference in these trauma patients.
Absolutely.
Or bleeding patients.
Right.
I want to make sure we emphasize that, because we do get the GI bleeds who are really dang sick, who are also suffering from this triad.
Absolutely.
And we're days behind the 8 ball now. You can also have the obstetrical hemorrhages. That there are so many home births in Texas. This is not something I encountered as a line provider in Chicago. But coming here to the Houston area, holy cow, home births are
a big thing.
So that's, I guess, that's the benefit of obstetrical hemorrhage, is we get a better indication on the time of insult.
Yes.
When the bleeding starts. So TXA becomes more of an option there.
Absolutely.
Because we can identify the time frame. And it will be very overt in saying that TXA and GI bleeds is a no-no, because we don't know.
Right.
We get
a 3-hour window for TXA.
We get outside that window and we start making things worse. So let's not, it's a Gene Kranz quote, space nerd, let's not make things worse by guessing, let's work the problem.
Yes.
So we can work the problem in a GI bleed. TXA is just not an option to working the problem. That's guesswork.
Right.
But trauma, we know the time of insult. Most of the time we got a pretty good idea.
Now you say that, and this is interesting, because I sat through a lesson a couple days ago. We talked in the lesson. We talked about raccoon eyes. Is it a head injury? Is it a basilar skull fracture? And the things that can look at. And then we started talking about oh God, I can't believe I'm spacing, but there's a Gray's colon sign, Gray's something sign. I can't remember. Anyway, but these are things, they're showing you different bruising patterns, things like that. And some of these are caused by fall that could have happened 3 days ago, because it takes 1 to 3 days for a bruise to form, right? So now I've got this bruise that's formed. They still could be bleeding. And like you said, I could be behind the 8 ball, especially if they're on like a low dose blood thinner, something else is going on. That's why it's very important. If you have a fall patient, hey, are you on blood thinner? That should be one of your first questions.
Absolutely.
Because that could dictate. Yeah, they may not be showing anything right now, but in a day, in 2 days, in 3 days.
Mm-hmm.
It could be a spleen lac that's just really slow. It could be a liver lac that's really slow. I mean, next thing you know,
Yeah.
you're like, well, I don't know why they're not responding, because they're bleeding out in their belly.
Well, Jay, you and I can talk for days.
Oh, yeah.
Because we've done that before. We've done it for years. Let's bring this around. We've gotten to say a lot of really good things. Any other comments that you didn't get to say? Any other thoughts on how bleeding kills somebody? Anything you want to close out with?
Well, you know, they talk about the bleeding is the number one cause of preventable
deaths.
You know, and that, I know we use that a lot in stop the bleed classes and things like that. And we're talking about tourniquets and direct pressure and all these things, but it really does apply even in these internal bleeds, even in these things. And it's all a matter of recognizing. It's all a matter of learning. Don't stop learning. Read the articles. I mean, even before I came to this, I read a few articles on the hypocalcemia because I wanted to be, freshen up on this discussion. But there's so much information out there about whether it's the triad, whether it's the diamond. The diamond just adds hypocalcemia to it. Whether it's about blood administration, who should, who shouldn't, blah, blah, blah. And you'll find docs that love blood. You'll find docs that are like, nope, it's not for us.
Mm-hmm.
But our outcomes need to be, 100% focused on the patient. And, so far what my experience has been with blood products and addressing the trauma triad or the trauma diamond, however you want to consider it, is it's just worth it. And I guarantee you resuscitate somebody with blood in the field, they're going to come back at some point and say, hey, thank you.
Mm-hmm.
I mean, they're the ones that are going to appreciate more so than a doctor or a nurse or anybody else. It's going to be that person that walks home and resumes their life with their family and can do the things that they need to do. And so we, as EMS providers, as people that are in this field, whether you're a basic to a doctor, we owe it to our community, to our patients, to be the very best that we can be. And it's important to learn these concepts, not just with this type of thing, but with anything that is, is life-threatening or, and could be life-saving. So that's really a big thing I got.
Love it. Jay, thanks for taking some time with us today. Appreciate
Thanks for having me.
The energy and the enthusiasm. Delivered just like I hoped you would. Had no doubt. So thanks again.
I do get a little long-winded sometimes, so if I did, I apologize.
And appreciate y'all for listening in. We'll catch you next time.